Everyone. Good morning. Thank you for taking our time to come to our session. Um, our session is titled Applications of Human-Centered Design, which is HCD, in Sexual and Reproductive Health. Today, I have with me some of my presenters here. I have Nicole Ippoliti. I have Jana Smith. I also have Ms. Janelli and Associate Prof. Mahesh. And they will do a better introduction of themselves when they come up stage. So today we'll be talking more about human-centered design, which is an approach that focuses on the needs of humans while designing programs for them or young people or anyone. You have to go through them to design programs for them. So human-centered approaches focuses on different strategies that are more beneficial to those who they are being designed for. And I'm sure my presenters will give you more information on today's session. Our first presenter that we'll be having today will be Nicole Ippoliti. She's the technical director of Y Labs. Please let's give her a round of applause.
Great. Can you all hear me okay? All right. Thank you, Peace. Thanks, everybody, for joining today. It's for some of you, it's what days of the conference is it? Day 2, day 3? Some of us, it's day 5, but we're all here, so thank you for being here today. My name is Nicole Politi. I'm the technical director at Y Labs, a design and research organization working to improve the health and well-being of young people worldwide. I'm also the co-chair of the Quality and Standards Working Group, which is a partnership with HCD Exchange that produced this framework that I'm going to be sharing here today. The framework was co-created and convened young people and experts in design and public health, really to develop consensus-driven quality standards for applying human-centered design to adolescent worldwide. How many of you in the room are familiar with HCD, just by a show of hands? Okay, so a good contingent of you. Well, hopefully today's presentation will help expand on it a little bit more. Great. So just in terms of an introduction, and for those of you who are unfamiliar with HCD, we have been, as a sector, applying human-centered design to SRH programming for almost 10 years now. And during that time, we have seen that HCD has shown incredible potential and promise really to drive SRH outcomes purely by the fact that it has had this emphasis of centering young people's voices, their experiences, their perspectives in the design of solutions that are meant for them. But up until recently, this year, honestly, there's been no consistent guidance or quality standards or definition of even what quality means when applying HCD to ASRH programming. And that has been a critical gap because when we are working as a sector with young, vulnerable populations on really stigmatizing topics like sexual health, we cannot afford to make any compromises or concessions when it comes to delivering quality with and for young people. So today I will be sharing a framework created and embedded by design and public health practitioners, many of whom are in the room today. I'm very pleased to have some of my co-authors in the room with me, which delivers agreed upon standards to drive rigor and credibility in the design process, elevate young people's agency in the design of solutions that are meant for them, and ultimately transform SRH outcomes for young people. So the process to develop this framework has been intensive and a very iterative process, one that was very much rooted in co-creation with the HCD Exchange community of practice. We started this work by conducting a scoping study with evidence derived from expert interviews and published and great literature of HDD projects over the last 10 years from sub-Saharan Africa and South Asia to really kind of give us an initial indication of what are the domains of quality that we should be looking at. We then convened an advisory group of partners from design, public health, evaluation, and funding agencies to help us draft the principles, the tips, and kind of curate the resources associated with each principle. One of the defining features of this framework was that it was conceived through a very strong interdisciplinary collaboration. And because of that, there's a lot of tremendous detail and nuance in this framework, and it is broad enough yet specific enough to be able to apply to all these different disciplines of public health, design, et cetera. Which is important because there's not just one discipline that is accountable for quality. We are all accountable for quality, from funding agencies to implementation agencies and everything in between. And then finally, this framework would not have been possible without the continuous and invaluable input from members of the HED community of practice who, through webinars, emails, interviews, really contributed to the development of the principles, the tips, and the resources that are in this framework. So I just wanted to give a shout out to them. So without further ado, I am very happy to present the 8 quality principles. And if I can summarize them, these principles really encourage us to commit to the safe and dignified and inclusive practice of engaging young people and community stakeholders in the design and implementation process, be adaptive and responsive to the evolving needs of the communities in which we are working, practice effective integration and collaboration of different disciplines. And these principles are really intended to be broad in nature. And like I said, they are accompanied with very robust tips. So I'll share the link at the end, but it's live and I highly encourage you to take a look at it because while these principles are broad, the tips are very specific. So we'll go over each principle now so you have just a deeper sense of what these mean in practice. I'm going to start with the first one off the bat. Meaningful youth engagement has really gained an increasing amount of prominence in the public health sector. Everybody's talking about it, right? And HED, by nature, is an effective mechanism to better center young voices in the design of solutions that are meant for them. So this principle really takes us one step further and says, we need to move away from tokenistic and extractive practices of youth engagement by making sure that we're engaging young people as actual partners in the design and implementation process. What does that look like? That looks like budgeting time in your proposals to recruit, compensate, and train local young people on HDD so they're well positioned to co-design and make decisions with adult team members. The second principle really talks about the equitable inclusion of different subsets of young people in design. So I think we can all acknowledge that due to time and resource constraints or pressure to scale quickly, ASRH interventions run the risk of engaging the more advantaged subgroups of young people. Those who are living in urban areas, they might have access to technology, they might be literate. And as a result, the more vulnerable subsets of young people, those who are out of school, who are digitally disconnected, the very young adolescent mothers, they fail to be effectively included in the design and implementation of youth-serving ASRH programs. So this principle really calls for a concerted focus on ensuring the equitable inclusion of these different subsets of young people. And there's a lot of tips in this section that help teams navigate the thoughtful and intentional recruitment and engagement strategies of these young people throughout the entire design process. The third principle really speaks to the importance of the safety and protection of young people, not just youth participants, but young team members who are engaged as design team members. And so the tips in this section are extremely thorough. They range from the development of risk and mitigation plans to ensuring there's an escalation protocol if there's an adverse event that happens, to working with local partners to identify supportive services that team members can refer to should a young person disclose any form of trauma or physical and sexual abuse. So really making sure, this principle is really making sure that we as a sector are really committed to the physical and psychological safety of all those who are involved in the design process, especially young people. Well, the fourth principle, for design to be effective, both design team and implementing partners must maintain flexible and open mindsets to support the evolution of HCD findings as they emerge. The key to this principle is really leading with curiosity, carving out time for pause and reflect moments, and building those into the work plan early, talking with your funding partners and making sure that you're really aligned at each stage of the process so that what you're creating can be immediately responsive to what you're learning, and taking time to stop and pivot if any surprises come up. Number 5, the use of primary and secondary evidence is emphasized here to ensure that we are, as a sector, as we're using HCD, that we're not recreating the wheel, that we are building on the lessons and the key findings from previous programming in ASRH. That the integration of what has previously worked with an investigation of what is new or unconfirmed is where HCD and ASRH can really gel together. But let's use secondary evidence at each stage of the process, from design research to prototyping, to making sure that what we're learning and what we're creating isn't recreating the wheel. Number 6. So the next principle is really about the intentional and routine engagement of stakeholders who have an influence on young people in their respective communities. This is really about just being quite intentional about building for the ecosystem. When we think about young people, it's so easy to design for young people in a vacuum, but they have all of these other caregivers and influencers in their life that we have to design for, just in terms of sustainability and overall effectiveness of our solutions. So the tip really is about making sure that we are identifying and being really thoughtful about the context-specific operational, structural, and political concerns that can be identified at the project outset and are accounted for throughout the design process. Second to last one. So Principle 7 highlights the importance of integrating and working across different disciplines as they pertain to health and well-being. And so in our review of the literature, we have found that the most popular disciplines to integrate in HCD projects have been behavioral science, market segmentation, behavioral science, segmentation, and youth-driven participatory action research. And so the evidence did affirm that the integration of these disciplines can enrich research findings, can provide a lot more depth and nuance to the design. But it also did caution that adding too many disciplines can also complicate the process, especially if it's not done effectively. So if there's not a lot of intention at the outset of working together, collaborating well together across these disciplines, the process will become more complex. So interdisciplinary partnerships do require a lot of human, time, and financial resources to ensure there's effective collaboration throughout the design process. Finally, Principle 8 speaks to the documentation of methods and decisions made throughout the design process. This principle really encourages project teams to use documentation as a way to be transparent, providing justification for decisions and connections being made throughout the design process, as well as tracking progress over the solution concepts over time. So in closing, I just wanted to recap the key takeaways from this presentation. The quality and standards framework has been created and vetted by young people, public health practitioners, designers, evaluators, and funding partners worldwide. The framework is a flagship and collective sector global good that guides the inclusive and effective practice of HCD and ASRH design and implementation. It is live now and available for your use. We really encourage, here's a link right up here. You can just take a picture of it, check it out. It's available. It is highly detailed, hopefully very user-friendly. If you have any feedback, come and find us afterwards. We'd love to hear, but we really encourage you all to take it for a spin. Thank you.
Okay. Thank you so much, Nicole, for your presentation. I believe it's important to integrate the different aspects of best practices in order to ensure human-centered design for young people. So thank you so much. Please, let's welcome our next speaker, Jana Smith.
Hello, everyone. My name is Jana Smith, and I'm from Ideas 42, a behavioral research and design nonprofit. And I'm going to be sharing a couple of case studies around using behavioral design to improve quality of care in SRH. So as way of background, Nicole keyed us up pretty nicely, but just to say that 10 years feels like a lot, I think, for all of us, but relative to many other approaches within global health, the application of HCD or behavioral design in our case is still relatively nascent. But there are many experiences around the world in many different settings that do point to the promise that these approaches can have to generate new innovations. And I'm going to be sharing 3 case studies today from Burkina Faso, Mali, and Uganda of using behavioral design for SRH. So in terms of methods, the approach that we apply is behavioral design, which is a fusion of human-centered design principles with applied behavioral science. So the first step is clearly defining a behavioral problem that can be measurable. Diagnosis typically constitutes of in-depth interviews and observation within the context in which we're working to identify the behavioral barriers as well as underlying drivers that are shaping people's behavior. Then the application of design thinking principles to co-design solutions that address those insights. The use of typically experimental tests whenever possible to more rigorously evaluate the effectiveness of those interventions. And then the magic of scale, which is less science and more art at this stage of the game. So the first case study that I'll be sharing is work from Burkina Faso. This work was done collaboratively with Pathfinder, with ICRW, with Camber Collective, as well as the Ministries of Education and Health in Burkina Faso. This work was focused on adolescent uptake of contraceptives, specifically unmarried adolescents in peri-urban and rural areas. In this setting, the diagnosis phase revealed a lot of insights that I think we're familiar with from other settings. Youth generally underestimating pregnancy risk and perhaps being overconfident in their menstrual cycle as a way to avoid unintended pregnancies. Certainly a little bit around not making an active choice around contraceptive use and somewhat getting sucked into sexual activity without necessarily confronting the implications of that decision. Identity threat, stigma, and a misalignment between the use of contraceptive methods and the identity that girls want to hold for themselves, as well as anticipated stigma within the health facility in this setting, more specific to fears around bumping into neighbors, family members who would maybe see them and report to their parents. So the solution set that emerged from the co-design process was really 3-pronged. The primary solution being on the left was a board game, which was implemented within the school system, both public and private schools, during lunchtime, in which groups of adolescent girls were brought together. The game constitutes of a series of sex scenarios where girls read about cases that very much came from the formative research that we conducted, were confronted with making decisions within the game around what path they wanted to choose, whether or not they wanted to take up contraceptives within the context of the game, which would lead to a longer path, but a safer path. As they spun, you can see the top at the bottom, which would indicate whether or not they would be pregnant and would be sent backwards in the game. Lots of opportunities for knowledge building, as well as advice giving among girls to really generate a lot of discussion. The game concluded with handing out of passports, which you can see on the right-hand side. All girls were given a passport for themselves, as well as 2 to share with friends, to again encourage girls to go together, to try to leverage peer influence as a way to also make the solutions more scalable. The passport was meant to concretize an intention to go to a health facility, as well as provide some basic information around the range of facilities that girls might be able to go to, where they may also be able to avoid people that they know. And then finally, within the facility setup, matching branding of a poster, with the idea being that girls could point to a poster should they encounter somebody they know in the health facility as a justification as to why they were there, for reasons other than for family planning, which girls feared would be the assumption. The second case study is from Malawi, and here we're focused on postpartum family planning, and specifically around facilitating active informed choice of contraceptive methods. In this setting, what we were finding is that women often didn't necessarily receive good quality counseling. Providers would often default to counseling first on the methods that were most commonly used and that they assumed that women would seek out, rather than necessarily being able to take the time to go through more in-depth counseling. Naturally, as we see in many settings, providers that were very bandwidth constrained didn't necessarily have time to do in-depth individual counseling with a lot of women. And then a lot of pushing women to make decisions before they were perhaps ready to around what contraceptive method they wanted to take up, and certainly instances of stockouts in which women would be encouraged to take up a method that wouldn't necessarily suit their needs, leading to higher rates of discontinuation. So using these insights, we arrived at a series of four solutions, which were all facility-based. The first being a gamified group counseling tool. So again, understanding that providers had limited time and weren't going to be able to do more in-depth counseling, instead trying to leverage moments when women could come together as a group to have more in-depth counseling. The counseling tool comprised of a large dice that had different colors. So the women would roll a dice and the color matched a different method. That way the order in which methods were presented to women was very much at random, rather than always having the same method that providers were pushing on women be the one that was presented. Additionally, we spent a lot of time coming up with method discussion cards together with the women to ensure that the information that was provided on each method better matched the kinds of questions that they had around methods, which hadn't necessarily been the case previously. In order to encourage women to take some time to either discuss with their partner or seek out more information on their own, developed a system of method referral cards in which women could somewhat commit to coming back at another time rather than necessarily feeling pressured to make a decision about a method at the moment, as well as a way to, should a method not be available, that a woman also feel comfortable returning at a different moment in time rather than needing to take up a method that was perhaps suboptimal. And then additionally, just a couple of job aids. One, to encourage family planning discussions during the antenatal care period, as well as an easy reference guide, as opposed to some of the more elaborate flip charts that aren't necessarily used by providers, just to give some good information on PPFP options. The final solution set, and I should mention that this work was done with the USAID-funded ONSE project, primed by Management Sciences for Health, as well as the Ministry of Health, of course, of Malawi. The final case study here is from Uganda. This was done with Marie Stopes Uganda, as well as some other partners in Uganda. Here, the insights were very similar. This was, again, adolescent contraceptive uptake and very similar findings to what we had seen in Burkina Faso. The solutions, given a different operational context of Marie Stopes clinics rather than public sector clinics, was a little bit different. The first solution set was that of refer a friend cards, in which girls were given a card to hand to a friend, as well as 2 bracelets, should they seek contraceptive counseling. So not contraceptive uptake, simply information within the clinic, to encourage girls to give the card to a friend, and then that girl would go get her own bracelets and encourage other friends. So again, really trying to leverage that peer influence piece again. Similarly to Burkina, some clinic posters that also address some of the identity concerns, in which contraceptive uptake was more aligned with the identity that a girl may hold for herself, as well as trying to make it easier and more personal for girls to engage with providers through these name tags. So we ran a randomized control trial. ICRW oversaw that randomized control trial in the case of Burkina Faso. In the case of Uganda, we also ran a randomized control trial. In Malawi, implementation occurred in the middle of the pandemic, so the solutions were adapted. There was not a randomized control trial. We instead did just a feasibility pilot. And in all 3 of the studies, we really looked to understand feasibility of the solutions, desirability of the solutions, as well as their effectiveness. So in terms of feasibility, all the solutions in all 3 settings were quite straightforward in the whole scheme of things to implement, which I think points to the importance of the design process and ultimately iterating to make sure that solutions fit the workflows and the context in which we're working. In the case of Malawi, we're able to quickly adapt the solutions to be employed by community health workers when provision of family planning was happening more at a community level in order to avoid centralization of people at health facilities. And I think the biggest feasibility question that we had with Burkina was whether or not effective game facilitation was going to be very person reliant in terms of the facilitator being critical to ensure good gameplay. But we did find that certainly a very skilled facilitator engaged girls more strongly, but that it was feasible and effective to apply the game even when facilitation wasn't perhaps quite as dynamic. In terms of desirability, the game was a huge hit. Girls actually requested in all of the schools to play a second time, and we found that girls who had not opted in to gameplay the first time did opt in the second time. Girls also talked about wanting a different version of the game to play with boys because they wanted to engage boys in those conversations as well. In the case of Malawi, providers very much remarked on the ease of use of the tools, and there were high levels of satisfaction from both girls as well as facility providers for the Refer a Friend program in Uganda. Obviously, a very quick blip on effectiveness here, given the time. In Uganda, we did see a statistically significant increase in adolescent visits for contraceptive uptake in the clinics. The publication is actually in the WHO bulletin that was published just this year. In the case of Burkina Faso, we did not see an increase in contraceptive uptake, but we did see statistically significant increases in certain contraceptive attitudes and beliefs. And in the case of Malawi, where we did not run an RCT, we did see a suggestion that referrals and method switching may have increased in a way that was favorable given the qualitative feedback that we received from those interviews. So just to wrap up, and a couple of broad takeaways looking across these 3 case studies is a very much, probably no surprise to many of us in this room, that leveraging existing channels and workflows very much facilitated adoption and scale. So there's a lot of excitement around the game in Burkina Faso, for instance, but that was a new programming channel to have the game be played in schools. And despite the enthusiasm and the results, it's been more challenging to find paths to scale, as opposed to the job aids, for instance, in the Malawi work were a lot easier for our partner to scale within their programming in other districts. I think certainly more work needing to be done in that missing middle. There's often a lot of excitement at early innovation projects, and then a desire that they immediately jump to scale without necessarily having a little more time to continue to design and tinker and figure out the best path to scale, even if scale was in mind from the beginning, and especially as it relates to bolder innovations. And finally, all of this work is mostly focused on either frontline providers or clients themselves, and we really think that there are a lot of opportunities to look at other actors within the SRH ecosystem, whether or not those be system-level actors, potentially feminist advocates, but different kinds of actors that may be influencing choice for women at a higher level within the system, and to use some of these approaches to try to see what insights and solutions can be generated from that. Thank you very much.
Thank you so much, Jana. Please, if you have any questions, we'll take them at the end of our session. I'll be calling on my 3rd speaker. She is the Senior Program Manager for excuse me, Ms. Janelli. Please let's welcome her. The Senior Program Manager of Innovations for Choices and Autonomy. Thank you.
Thank you, Peace. Hi, everybody. My name is Janelle Vayin, a program manager at the University of California, San Francisco. And today I'll be presenting on a research project entitled Attention Online Shoppers, utilizing a human-centered design approach to identify intervention opportunities to improve contraceptive access through an e-commerce platform in Kenya. And my co-authors are listed below. So first we'll dive into a bit of a background and aims. The Innovations for Choice and Autonomy project aims to identify promising approaches for implementing self-injection of DMPASC within a full basket of contraceptive methods. And so today I will be discussing the human-centered design scope of work done by the Kenya Medical Research Institute and the University of California, San Francisco. So despite the growing number of e-commerce platforms in sub-Saharan Africa, few are specifically focused on offering sexual and reproductive health products, including for self-care products. And so in 2018, actually, the self-injection label was approved by the Pharmacy and Poisons Board, the National Drug and Authority in Kenya. Thus, our intervention design aim was to evaluate and to design and evaluate approaches for introducing and supporting the use of this self-injectable in the context of a full basket of options through an e-commerce channel in Kenya. So we partnered with Kasha, an e-commerce women's health and personal care web service in Kenya, to better understand the goals and the needs of current and potential shoppers on Kasha. So we also aim to identify opportunities to improve access to contraceptives, including the self-injectable. So just a quick poll here. Who has ever purchased anything online? Show of hands. Wow, almost a full room. Next question. Who has purchased health products online? Okay. And now, who has purchased any form of contraceptive product online? All right, a little bit less than the first two. Now, an added question, who might be interested in purchasing contraceptives online? All right. Thank you all for participating in that quick poll. So now we'll dive into the methods. So we applied a human-centered design approach, which includes several phases, such as research, analysis, idea generation, and prototyping. But today, I will focus on the steps that we took in the first diamond, also known as the research and the analysis phase. So from November to December of 2021, we conducted 8 observations and 7 interviews of current and potential customers of the Kasha website to understand their needs and challenges when shopping online. We also conducted 4 observations and 5 interviews with Kasha staff, including a nurse, a pharmacist, and 3 customer service representatives. We did this to try to understand how they responded to customer orders. We also conducted in-depth interviews with 3 stakeholders, a youth advocate for a sexual and reproductive health organization, a gynecologist, and a project manager for a local contraceptive provider. Next, we added our data points to an online whiteboard known as Miro, and categorized all of our data points into themes through a process known as affinity mapping. So we clustered together our themes, and then we're able to create interim analysis outputs. And so these interim analysis outputs included insight statements. So insight statements were used to capture participants' needs, their pain points, and opportunities for intervention. We also then created personas, so a synthesis of a type of a person whose goals and characteristics represent the needs of a larger group. And then the last output that we created is a journey map to dynamically identify the user's pain points and opportunity points when they're engaging with e-commerce. And so now I'll actually take you through what those analysis outputs look like. So first up, the insights. We came up with a total of 12 insights and categorized them into 2 buckets. So one related to general online shopping behaviors, and the second related to health and contraceptive product shopping behaviors. So today, I'll actually focus on the insights that are unique to the self-injection journey, though the others were relevant for other aspects of the solution development. And so this is the second analysis output, personas. We created 2 personas, an older and a younger profile. And I just want to acknowledge that although our younger profile here is actually a university student and may not have the highest unmet contraceptive need, we acknowledge that young women in Kenya have a unique need because they tend to shy away from going to health facilities to access contraception, as others have mentioned, for fear of judgment and stigma. And so I'd like you all to please meet Jerry. Jerry is a university student. She lives with her parents. She uses condoms, also uses her computer and her cell phone, but she doesn't shop online. So her overall goal is to be able to learn more about contraceptive methods from a trustworthy source and to be able to privately acquire them. As far as her goals and needs, she needs to know that her products will be delivered, that she can purchase stuff in a private environment, and that she will receive tailored information to help her decide on a contraceptive method. As far as the frustrations and the pains, they also align with the goals. So currently she doesn't shop online because she feels that she might get scammed. And she doesn't want to feel judged or stigmatized when she's shopping for contraception. And that's illustrated through a quote here that Jerry says, "There's stigma when I purchase condoms from the pharmacy. I feel judged from the other customers and the pharmacist." So as I mentioned before, I'll focus on 4 insights that are most important for unlocking the e-commerce channel for self-injection. So we'll go through that in Jerry's journey. So here we have the first step. Jerry needs a contraceptive. So what does she do? She decides to use Google to do some research on different contraceptive methods. However, she quickly becomes overwhelmed by all the information that she finds and wishes that she could talk to somebody about it privately. So we'll dive into the first insight. An informed choice is your best choice. Currently, we know that there is a wealth of information available at health facilities, social networks, and online. And as I mentioned, the frustration here is that despite all this information available, women may not be able to make an informed choice without access to personalized information. And so the opportunity here was to build awareness that Kasha is a trusted source of both high-quality contraceptive information and products, a one-stop shop, a place for people to go to. So next step, she navigates to Kasha. How does she do that? She discovers on social media that Kasha offers contraceptive methods. However, she still feels wary of shopping online for fear of getting scammed. And so she actually talks to a friend about Kasha who has used it before. And so that eases her fear a bit, and she decides to try it out. So this is some social norms between peers. And so this will lead us into the second insight. How do I know you're for real? We saw this a lot through our data that people currently that mentioned there's a lot of online scammers and that it's a prevalent situation. And so people have a hard time of actually fully trusting shopping platforms. And the frustration here is that Kasha is doing some efforts to bring awareness to the fact that they're a credible source, but not many people actually know about it. And so then there's a need for Kasha to clearly communicate their credibility among people who are actually dubious of shopping online. So once Jerry's on Kasha, she browses for contraceptive. So she clicks on different methods to compare their uses and their side effects. And she decides to privately chat with the nurse on the existing chat platform on Kasha to receive some personalized information. So this insight is titled Information Tailored to My Needs. We know that women want to receive personalized information on what contraceptive will work best for them. However, the frustration here from some of the interviews we heard is that there is variability in the quality of contraceptive counseling and information that women receive from healthcare providers. And so the opportunity here is that there's a need for women to easily access confidential and personalized information from an approachable and knowledgeable source. So now we'll jump into when Jerry chooses what to purchase. The nurse ends up identifying some of Jerry's preferences, the fact that she doesn't want to have to go to the facility all of the time, and that she wants a method that she can use covertly. And so they discuss several options, including self-injection, which is new to Jerry. And after their discussion, Jerry decides that she wants to try it out. So this insight is titled, Tell Me All, the Good, the Bad, the Ugly. So most women have actually not heard of self-injection in this context. And when they hear about it for the first time, they want to be able to immediately learn more. The frustration here is that women are really concerned about the risks and the limitations of self-injection, given that it's a new product. opportunity here is that we want to provide women with holistic information on self-injection, including its benefits, its limitations, how it's used, and how it's acquired. And so the next steps, Jerry places her order. She likes the fact that the delivery will be discreet and at a place of her choosing. She receives a call from the nurse to confirm her order. She then is contacted by a delivery rider who's going to bring her order, and then she receives it in a discrete part of the university. And so now we'll dive into the discussion and conclusion. So I wanted to give you all a preview of the solutions that we came up with, and was able to map our insights to the intervention components. So for the first one, how do I know you're for real? We designed a set of posters to place in strategic locations where women gather, such as hair salons, to be able to establish and demonstrate that Kasha is a trustworthy source of quality information. So this is an example of what one of those posters looks like. For the second insight, an informed choice is your best choice. We actually redesigned Kasha's contraceptive webpage to include videos on contraceptive methods, FAQs, and a comparison chart. And so building on the comparison chart for information tailored to my needs, the comparison chart has a sort and filter function where people can then decide to choose between the duration of the method, whether it's hormonal or non-hormonal, things like that. And then for Tell Me All, the Good, the Bad, the Ugly, we redesigned the self-injection landing page to include steps for how to self-inject, videos, and waste disposal. And then I think I just missed the chat one. For the nurses' availability, we were able to clearly indicate when the nurse is available so that people were able to have an idea of when to come back to Kasha if, for example, she wasn't available at that time. And I think that we learned a lot about being able to talk to a real person. For them to be the messenger was really important for women who are seeking contraceptives. Oh, yeah, sorry, I forgot to add in the self-injection one. So that's what that page looks like. And that brings me to the end of my presentation. So I just want to go ahead and acknowledge the ICANN consortium research teams, all of the participants who consented to this study, and of course our funders, Bill and Melinda Gates. So thank you all.
Thank you so much, Zanelli. Please let's welcome our final speaker, Professor Mahesh.
Great. So as my presentation's coming up, I have the distinct advantage of going last and being able to utilize all of the previous speakers' engagement, including from Jenna, who has given me great context from Malawi. And actually, we can almost think of this as a co-creation process, because when IDS 42 was actually engaged with a lot of the formative work that you were discussing, I was also developing this very same intervention and design. So we co-created without, like, simultaneously, even though we were not on the same project. So I really appreciate this. So the title of this presentation and the study is Exploring User-Centered Counseling in Contraceptive Decision-Making and Experimental Evidence. So we run a field experiment in Malawi, and this is joint work with my student, Keixing Zhang, who's now an assistant professor at Renmin University of China. So I think I don't need to tell very much of the people in this room that family planning is a bidirectional process in service provision where clients come in with sets of preferences and where, like, either over fertility, over birth spacing, over methods, method choice, and it's the role of the provider to guide clients to inform and help them to realize their preferences and achieve outcomes that are desirable to clients. So the outcome that we're looking for in family planning is where there's concordance between what women and clients say that they would like and what they actually end up doing. So the concordance component is really, really important. So in the context of not only Malawi, but globally, we see that contraceptive prevalence has been increasing substantially in many parts of the world. And in Malawi, over the past 10 years, contraceptive prevalence has really, really increased from like 46% in 2010 to almost 60% in 2016. But in spite of this increase in contraceptive prevalence and use, one must always ask the question, are women truly using the best methods that in fact actually reflect their preferences? And actually, when we look at the data, this is all from Demographic and Health Survey data, 37% of women who were using discontinue within a year for non-fertility reasons, meaning they don't want to actually get pregnant again. They're discontinuing for method-related reasons, for dissatisfaction, and all the reasons that we all have identified in this room. Like, many people here are have much more expertise on these reasons than even I do, right? And there are frictions that exist in women's realization of their method. So how women actually end up seeking their method and how they end up using what they say they want has always been a challenge in terms of realizing their ideal method. In this framing and environment, there is a significant emphasis of family planning programs to provide full, free, and informed choice over all methods. And as a result of this key priority since ICPD, there are significant resources in family planning to provide complete information. And the approach emphasizes the role of counseling as the entry point for providing full, free, and informed choice. And in the case of Malawi, the current family planning practice, as Jana actually mentioned, is that there's a group counseling component, which is often where women are introduced to counseling in a group setting, and they're provided with counselors actually go through a set of methods, and I'm sure not only in Malawi, but in other settings, you have the flip chart, where you're going method by method by method through a full series of about 15 different flip charts. So actually the Kulera flip chart looks like this, where the methods are actually, it was designed by the Ministry of Health, and there's about 13 methods that are gone through, including starting with the most effective methods, and then essentially ordered implicitly by order of effectiveness. So the aim of this approach is to actually achieve informed choice, where you're providing the full range of all methods that are available. But how does such a counseling approach actually do in helping making women have informed choice and allowing women to have informed decision making? And what do I mean by informed decision making? Women come in with preferences. Through the counseling process, they're able to update their beliefs and preferences over methods and over decision making, and they're able to actually realize and act on those preferences through behavior. And this is where we ask the question throughout this entire panel, to what end are such approaches actually user-centered, where the client is a focal point of interaction, preferences are elicited over the process and in the interaction with the health system, and they're actually able to realize those preferences. And I know Janelle and her colleagues at UCSF have worked on my birth control, and there are many examples in this room on human-centered design. So to contribute to this evidence, we conduct a field experiment in Malawi where we test elements of user-centered design. We specifically test how to think about the role of user-centered design through short, tailored counseling, where clients are thinking about the concordance in what they say they want and what they actually end up doing. And we also look at the role of male involvement, where clients and women have the option to invite their husbands or partners to counseling, and they're the key focal point of that decision. So we work on this experiment with 782 married women between the ages of 18 to 35 in Lilongwe. And as a preview, I want to give the preview of the results, where we find that women who received short, tailored counseling, where we actually asked them and primed them in thinking about a contraceptive method. What features of the method are important to you? Is it duration? Is it effectiveness? Is it, no, I do not want any side effects? Do I want my partner or husband to be involved? Should it be coitally dependent? What is a feature that is important to you? And based on their most valued elicited feature, if we tailor the counseling process to that feature, women who received that type of counseling were more likely to change their stated ideal method over time, but they were not more likely necessarily to be able to act on that stated ideal method by changing their actual method use at follow-up, even when given the opportunity to change their method choice. And so they were more likely to actually be discordant in their ideal method use at follow-up and their actual method use at follow-up. Their stated methods, so their stated preferences for contraception, did not match their contraceptive behavior at follow-up. On the other hand, women who were encouraged to invite their husbands or partners to counseling were less likely to actually change their stated preferences. They were less likely to change their minds on what they wanted to do. But whatever they had said, conditional on what they had said as their ideal method, they were more likely to be able to act on that preference through changing, through their behavior. So, and they were no more likely to be discordant between what they say at the end and what they actually do. So a few more details about how this experiment worked. So it was a 2x2, it was an experimental design where we randomized women to either short counseling or the traditional flip chart method. And we cross-randomized with women who were either encouraged to invite their partners or they were just, it was just an individual counseling session, but women could also, in the individual counseling session, invite their partners if they so chose. But we weren't encouraging them beyond standard individual counseling. And so the reason why so in the husband and partner invitation, they were allowed to choose whether they wanted to bring their husband or partner to the counseling session. And this differs a lot from traditional and from existing intervention studies in male involvement, where oftentimes in male involvement, the husband or the partner is compelled to be brought into the counseling session as part of the design feature itself. But we know from service provision that partners are not, husbands and partners are not compelled to be brought in. And so this, to reflect more the actual means in which service provision is rolled out, we actually give women the choice to invite their partners or not. And in the short tailor counseling, we actually elicit the preferred methods and attributes based on a very simple question. So the question is, going back. In choosing a contraceptive method, which features were most important to you? And this was an open-ended question. Women were allowed to say as many features or choices as they wanted to understand attributes. We were not targeting or anchoring on methods. It was about attributes. Duration prevents against HIV or STIs, easily available at the clinic, does not require resupply, and women could list as many attributes as they wanted to. Then, after they elicited the attributes, we elicited the top attribute by asking women to rank across their top attributes. So we actually gave them counters, and they were actually able to put weights on which attribute was the most important for them. Then, what we were able to do is that we then were able to map, based on the attribute that was most important to them, we mapped the set of methods, up to 5 methods that most accurately mapped to that attribute that was preferred for women. So if women said that duration and effectiveness was most important to them, we focused on those methods that reflected that attribute. And then we provided attribute-specific flip charts. So I just want to make a comment that this was one of the cheapest interventions that I've ever done, because all I did was I took the flip chart that the MOH and RHD did, I just ripped out pages, and I just created 10 different types of flip charts with just a subset of attributes. So for anybody who's looking for a cost-effective intervention, this is it. And so after they got the intervention, we now asked them, pre-counseling as well as post-counseling, what was your ideal method? What was your ideal attribute? And but the main important point from this is that a woman could still state. A stated preference is still a hypothetical preference. We want to target that and link it to actually being able for her to realize that preference, depending on what she said. So after counseling, we then gave women a set of services for 1 month at a family planning clinic. So women, for 1 month, immediately following counseling, were given free transportation, a private taxi from their homes to the clinic and back, coverage of all family planning related costs for a full set of methods at a private clinic that was never, that did not have any stockouts, had low waiting times, that had very high quality of care. Mobile credit to actually make appointments with the taxi driver such that they could decide when they would want to go and receive care. So this is actually seeing the linkages between what women said they wanted at counseling and being able for them to act on that counseling preference. And so this is actually the ID cards that women actually received with all the information for counseling. This was the taxi service. So we actually have the taxi that was pick women up from their households to the clinic and back. And this is the clinic in Lilongwe where we actually took women to receive a full set of services. This is the PSI Tunza Clinic system, where this was a high-quality PSI clinic that was identified, and thank you to our PSI Malawi colleagues who actually were able to provide a full range of contraceptive methods services, including insertion, removal, clinic resupply, everything. Yeah. So following this, we actually had data collection after follow-up. So we followed women up at the clinic for those women who chose to come to the clinic. If they weren't coming to the clinic, or if they went to a different facility, because we also reimburse women for any other contraceptives and family planning services they got at other facilities, we followed them up by phone. And if we weren't able to call them by phone, we actually went and did home visits to make sure that we had complete data collection. Our key outcomes are changes in stated preferences, what women said that they wanted from counseling, before counseling, to at follow-up. So when we found them again either at the clinic or by phone or by home, did they change their stated preference methods? Changes in actual method use. So it's not just about stated preferences for methods, but actually what they did in terms of contraceptive behavior was also measured at all time points, from baseline to counseling and to follow-up. And so by measuring both stated preferences as well as revealed behavior, we're able to actually understand concordance, what women say they want to do and what they actually ended up doing. I think that before I even present any of the experimental findings, which I've already given a preview of, I just want to highlight, this was a 1.5 to 2 month follow-up, and this is my other whole thing about preferences and how unstable or how malleable preferences truly are for women in any setting. 40% of women are changing their minds, and it's not just saying that, oh, I forgot what I said before in a method, and now I'm changing my mind. They were actively changing their minds, and they were pretty adamant about it. This is not something where it was like it was memory or like uncertainty or indifference. They were actually saying, I'm changing my ideal contraceptive method. But only 18 to 20% of women are actually changing their method use. So there's clear gaps. Like even before I talk, these are the temporal changes across every single time point where we have data to show the changes and the dynamics of preferences and of actual behavior. So this is actually something I presented as a preview, but I want to just quickly go through some of the numbers where women who were assigned to this short tailored counseling were significantly more likely to change their stated ideal method, but they were not more likely to switch their actual current use method from counseling to follow-up. They were less likely to actually be using their stated ideal method at follow-up, which essentially translates to the discordance outcome. They were much more likely to be discordant between what they stated and what they were doing. And one of the reasons, what is interesting about this is that this is actually highlighting the relative inability for them to actually act on their change in preferences in spite of getting increased access to services through our intervention. On the other hand, women who were encouraged to invite their husbands were less likely to change their minds over their time period. But they were more likely to switch and actually change their use of contraception from counseling to follow-up, and they were more likely to be concordant at follow-up. They were no more likely to be discordant at follow-up. And what's interesting about this point is actually something which I wanted to conclude on, which is how is the interaction between women's preferences and their husbands' preferences actually playing out in their decision-making. So just to quickly conclude, both interventions speak to these elements of user-centered design that I think all of us in our panel have been discussing to date through the mechanism of counseling. And both of these interventions really were trying to seek to understand women's and prioritize women's preferences and move closer to this operationalizing the goal of informed choice in the family planning space. But neither approach seems to really give a clear sense of what a strictly preferred outcome would be. Because in the short Taylor counseling, it encouraged women to more freely express and change their minds, but these preferences were not more likely to be realized through their behavior. On the other hand, women who were encouraged to invite their husbands they were able to translate their stated preferences to be realized at follow-up, but these stated preferences are now confounded with what their partners or their husbands may have also wanted. So women's individualized preferences may have actually been crowded out through a joint realization with what their husband said that they wanted. So a woman's stated preferences at follow-up was encouraged and who brought her husband to the clinic and who brought her husband to counseling is now conditional on her husband's preferences as well. So it implies that a woman may have changed her mind because of her husband's presence. So was this change of preference wanted? So these are the questions that I think our field is still grappling with. Was this change in preference wanted? And is this a good outcome? And if not, are we deviating? Like, what does this deviation from a stated ideal method mean when you're bringing a husband together or a partner into the clinical setting and into the family planning service provision setting from the personal, individual preference that women may have had for methods? So I think that, in thinking about this from the welfare perspective, there's a much larger need for our field to explore this trade-off that women face between making independent choices that reflect their individual preferences, but possibly their lower ability to be able to act on them, versus incorporating their partner or social preferences to make jointly socially better off decisions, but not necessarily individually better off decisions. And so with that thought, I will stop.
Thank you so much, Prof. Please, if you have any questions.
Thank you. Hi, everyone. My name is Kaya. I'm with the Health Policy Plus project. I just wanted to say thank you to all the panel. It was a super, super interesting session. My question is for Dr. Kara, and I was hoping that you could tell us a little bit more about why there was so much discordance. What are your theories, and whether you were actually able to have any follow-up interviews with the groups of women, I think it was in the first group, who were certainly changing their preferences, but not realizing those to get at that why. Thank you.
Are we taking one at a time, or? Are we taking one at a time, or are we taking multiple? One at a time? Okay. So thanks, Kaya. So I think the challenge was to think about variation, that there was variation in not only preferences, but also strengths of preferences. So we actually have data based on how many counters women were putting for each of the different attributes to be able to show that women who, there were some women, of course, and actually about 40% of women came in and said, I know my preferences, I know what my attribute, my ideal attribute is, I want a method that prevents pregnancy, and that's the attribute that I'm really anchored to. And then there were a lot of other women who were coming in and saying, I have multiple preferences over multiple attributes. I want a method, but I also don't want side effects. I want something that prevents pregnancy, but I also want something that includes my husband. And that overlap, that mapping from attributes to preferences to outcomes is something that I think that our field is still trying to have a formalized theory of linking, of linkages between what does it mean to think about attributes? Because each method has a variety of attributes. And there's a lot of variation across methods, and there's no strictly dominant method, where one method fits all women of all types. And that's what makes this variation interesting, and what we actually find is in the discordant, the women who are more discordant, were also women who were more likely to have more equal weighting across multiple attributes. So one of the things that in our study did is that we currently only counseled women on that first attribute, on the primary attribute. But if that primary attribute's preference is relatively weaker, where they may be not as strictly preferred, then thinking about how to counsel women on multiple attributes, which means using multiple flip charts, is something that we are actually innovating on right now. Yeah. So that adds more time and burden on the service provider, because you have to now counsel women on multiple different factors. But that's something which actually requires that type of innovation to see whether that type of counseling actually strengthens and stabilizes women's preferences even over a short period of time as a 1-month follow-up. And we're also doing longer term follow-up. We just finished the survey 2 weeks ago on 3-year follow-up and where we can look at discontinuation. Yeah.
Hi, I'm Sunita Sharma, Director Propel Health, Palladium. My question is Janali. Actually, I have two questions. So one, I would like to know, do you know about other e-commerce platforms or companies providing essential medicines, also contraceptive methods? So this is one question. And Mahesh, the composition of your women's group, was it like they were truly representative in terms of rural, urban, less educated, more different, and poor versus, well off? All those, wanted to know that.
Yeah. Thank you for your question. The other one in Kenya that I'm aware of is Maisha Meds. It's called Maisha Meds. And I know that they are also providing contraceptive services in Kenya. Yeah, no, I'd love to hear if there are others in the room that know of other platforms, but that's, to my knowledge, what I know.
So thank you, Sunita. So the sample of women it's a particularly selected sample. So these are, and what's interesting is to see that these are women who already probably had a lot of access before, because these are urban women from urban Lilongwe, 18 to married women, ages 18 to 35. Relative, like there's some distribution and variation in educational attainment as well as in socioeconomic status. So to the extent that they're representative of married women who are early on in over their reproductive lifetime in urban Malawi, they could be, you can weight them up to be representative. But this is urban Malawi, urban Lilongwe, where contraceptive prevalence is very high, but based on the initial statistic that I showed, where almost 40% of women are switching and discontinuing their methods for non-pregnancy or fertility-related reasons, this is still an important insight that we could probably generalize to. Yeah.
Hi, this question to Jana. Hi, I'm Angela Dawson. I'm from the University of Technology in Sydney. And so I was really excited by your game. And I just wondered, obviously, user-centered design involves co-design. So how were adolescents involved in creating that game? I might have missed it, I'm sorry. And the other thing related to that game is, talked a lot about avoiding pregnancy. Can you tell me what other information was combined, particularly around maybe STIs and pleasure in sex, for example? Was that a bit risque in that? And if I could just ask Janelle a question too about your e-commerce, very interesting, cool thing. I'm very excited about that. But I'm wondering about the link to the public sector in terms of health referral in the case of adverse reactions, skin reactions, and so on and so forth. Thank you.
You can, yep. I can tell myself that you can all hear me. Thanks for your question. In terms of the co-creation process, the game was more intensive in terms of its design than some other solutions. So we did multiple rounds of both co-creation workshops and probably 4 full weeks of iterative testing with girls. We went through many, many, many different versions of the game. Avatars versus not, single player versus not, what kind of content, what would resonate, how to close out the game to drive action, how to think about facilitation to actually drive discussion, because there was very much a perception at the beginning we started testing that the facilitator needed to be an SRH expert, and then it ended up taking this very kind of teacher-student dynamic, which was really not what we were looking for, instead of actually having that facilitator be able to generate a space for discussion for girls and certainly clarify questions and be somewhat knowledgeable, but not be perceived as the expert. So a lot of fun co-creation. It was a fun one to design for. In terms of the game content, we went back and forth with whether or not to include STIs, whether or not to talk more about sex and pleasure. We're somewhat constrained in terms of how much content do you put in there? Do you end up distracting attention? We were trying to squeeze it in lunch break within the school system. So how long can the game be? If we add too much content, does it end up inhibiting discussion and ability for girls to actually talk after the game? So we ended up opting against that. So the content that was included was around contraceptive methods and, facts and, a lot of girls. There were just knowledge gaps in terms of what options were available to girls. So they were called quiz cards, and that was more about just building knowledge and confidence in what their options were. something that we called advice cards. There's a good amount of behavioral evidence to suggest that when we are put in a place where we are giving advice to others, it can enhance a sense of agency. So we ask girls to give advice to other girls in the context of the game, and sometimes by providing advice on how to confront an erroneous belief as an exercise to also say out loud why that belief that they themselves might have thought they held before, why they would explain it to a girl in a different way. And then a lot of the sex scenario cards, which was really the core of seeing over and over and over again a situation that girls could very much empathize with, and then spinning the top to see whether or not they would be fall pregnant or not. And that also created a lot of the excitement in the game. Girls would screech if somebody got pregnant. So yeah, there was a trade-off there, and we did hear that, I mean, they wanted to play the game multiple times, the possibility of having booster packs to potentially incorporate other content like STIs or pleasure.
Yeah, thanks for your question. I think the link to the public sector in case of adverse reaction. So Kasha actually links to private clinics at the moment, which even when especially if you're seeking a longer term method like an implant or an IUD, they make the referral to the private clinics. The Kasha nurse is when she talks to somebody who's seeking contraception, she does ask them, if they were to experience any adverse effects or experiencing other side effects, that they can call her back to discuss those. But then she would probably end up referring them to the closest public sector clinic. So that's currently the process.
Hi, my name is Sarah Burse. I'm a technical advisor with Management Sciences for Health, and my question is for Jana. Hi, we worked together on the Malawi game that you talked about. I wanted to push you a little bit because your comment about needing more work in the missing middle between innovation and scale really resonated with me. I think we recognize the value of human-centered design, especially in adolescent and sexual reproductive health. We've worked in it in the maternal health space as well. And we often design this within the context of a 5-year project with a certain amount of funding, with lots of external factors that can impact scale up, such as the pandemic that we face in Malawi. So what can we be doing to better address this missing middle and ensure long-term scale, but also sustainability and local ownership? Moving beyond who the implementing partners and designers are, how can we make sure that once a program ends, our innovation becomes sustainable? Thank you.
Definitely a great question, and I certainly do not think I have all the answers, but maybe to throw out some thoughts. I do think that some of it is around funder education. So I think there are funders that very much understand that a timeline for something that's truly innovative may go beyond 4 years, because that 4 years requires meaningful engagement, stakeholder involvement, iterative design, testing. That all takes time. And you're going to end up cutting corners on how to meaningfully engage stakeholders if you try to rush to scale too quickly. And then I've seen other funders that say, okay, great, innovation project done, scale up immediately to 30 districts from 1. So I think there is a bit of a funder education piece. I do think that we can maybe think a little more creatively ourselves around, running smaller pilots, perhaps a larger scale test in one setting and maybe smaller scale pilots in others. I think it ends up always just being challenging with resources and how to manage. I think on this scale up and how to think about sustainability, I think there's a lot more to dig into. I mean, from a behavioral perspective, I've thought about, are there ways to try to work with stakeholders, not only on, I think we do a lot of workshops, we get everybody on the same page, we make sure we understand priorities. In theory, we're designing solutions that could be incorporated from a cost perspective, but then that often doesn't happen long term. Could we be thinking about working with government stakeholders to actually concretize what budget would this hit? Who would be funding it? What other choices might you be choosing between? What other projects do you have ongoing that you're considering scaling up? Actually trying to make that concrete rather than, I think it's often a little more philosophical. Great, we like this idea, this is great. And then when it actually comes time to have it hit a budget line item, it's not there. So I think a lot more work could be done in that front to also help on the sustainability front.
Thank you. Our final question before we come to conclusion.
Thank you very much. My name is Philip Oluwayemi, monitoring M&A officer at HAF Nigeria. I wanted to ask about scale up, but that has been overemphasized. But I was just curious to know, was there any negative unintended consequence in terms of parents disallowing their children from playing a game? For example, there was one intervention we did in Kano, Nigeria, education. We gave some children mobile phones to play games with and read, and a particular father had to send the wife out of the house because he had instructed the woman not to allow that boy use the phone. So were there any instances where parents were opposed to their kids playing the game? Thank you.
Yeah, I think to me this was probably my biggest surprise on the Burkina project in particular. We spoke with parents in the formative research phase to try to understand what conversations were they having, what did they know about the sexuality of their kids. Obviously found a lot of differences by gender of the child, gender of the parent, life stage. Parents were actually involved in the design process of the game and were invited to partake. They were not playing the game with the kids, but the parents were very cognizant of what content they were going to be exposed to. And I was actually quite surprised that the schools and the parents were as on board as they were with playing the game. So we actually didn't encounter problems. And that's very much due to Pathfinder, engaging all of the right stakeholders, being able to convene parents and engage in meaningful discussion. But that was a surprise to me because I thought there would definitely be more pushback.
Apologies, we have like 4 more minutes, so we can take one.
Thank you very much. I'm George Barige, and I work as the Regional Technical Advisor on RH for PATH. My question goes to Dr. Miles. You mentioned about finding out if you were able actually to do an analysis on some other variables, like for example, the age. And also if you did an analysis on, for example, finding out whether they were new users or reviews, because that may have actually a strong implication in terms of making decisions. Like, for example, the people who have had maybe who have had experience before, they may be likely actually to have strong choices on what actually they want. Thank you.
Okay, I think it's me. Okay, great. So we definitely see that the main, I didn't present all of the subgroup findings and the discussion, the breakdowns, but we don't see much differences across different age groups of the impacts of both the short counseling as well as the partner involvement. It actually seems to be a relatively homogeneous impact or treatment effect. What we do see is that there is a difference between new users versus users who are switching, who are actually changing their minds. And actually what you find is that the bulk of the impact on the differences in state preferences and the discordance, where the discordance is coming more from, are from switching. From women who have used and are currently using and who are thinking about changing to another method. There's far less discordance between women who are new users, who are going from changing their minds from not using to using. And there's no real differences or impacts on women who are discontinuing. So they were using a method, and then because we also accounted for the fact that some women, through the counseling and also through stating their ideal method, they could say they don't want a method anymore. And we actually find that there's no differences or variations, particularly in the male involvement group on discontinuation. There is a little bit of an impact on short-tailor counseling. Yeah.
Thank you so much for coming to our session. This concludes it. Please do enjoy the rest of your day. Thank you.